He is the former professor and head of the Department of Neurology Department of SCB Medical College. He passed his MBBS in the year 1970. He is the former professor and head of the Department of Neurosurgery Department at SCB Medical College. He has passed his MBBS in the year 1973 and he has done his MS in the year 1975 and both from VSS Medical College. He has done his MCH from SCB Medical College in the year 1985. Thanks to all the chairpersons on the dais. Now I would request the chairpersons to carry forward the session. Thank you.
Good morning. It's my proud privilege to chair the session. I must thankful to Professor P.K. Sahu for this opportunity. This session will discuss about spinal cord injury, and our first speaker is Dr. Ellen Teparty, the noted neurosurgeon in Calcutta, and he will speak on cervical cord injury guidelines and evidence-based management. Dr. Teparty, please.
Thank you very much, Professor Ghosh, Honorable Co-Chairpersons, Dr. Lenka and Professor Kumar. Respected teachers, I always say that when I look at my teachers, I feel very proud and feel also humbled, as well as I feel I am a child, and that keeps me going. Respected co-delegates, co-speakers, residents, ladies and gentlemen, I was going to thank Dr. Yu. I told him, where is Dr. Yu? Are you there? Thank you very much for spoiling my party, because we are basically speaking on the same guidelines. And also, since Professor Kale is speaking on C1, C2 after me, I will be limiting my this talk, which is cervical spine injury guidelines and evidence-based management, to subaxial spine only. Now, between Dr. Yu and Dr. me, what it means is, and we have discussed this on head injury as well, so in addition to that, spine injury, the guidelines are difficult to make, more difficult to follow, and still more difficult to really report and improve. That is why we have these guidelines few and far between. But then you can ask me, why guidelines? Because guidelines provide the best evidence. But remember, it is only the evidence that exists. In future, there may be something better. We will adopt that as well. Now, why evidence-based medicine? Because organized neurosurgery created the evidence-based recommendations. And that is why we will do EBM. And as we know that guidelines can provide firm and easily applicable guidance, or at least we hope. For example, the non-use of high-dose methylprednisolone. I think most centers have stopped using it. And this morning I sent another email to my colleagues. One of the colleagues is little truant and he wants to use it. I said, don't use it in spinal cord injury, please. I will discuss that a little later. Clinical practice guidelines need to be balanced against the cost of application. Very important to our Indian setting. People can do microdialysis, people can do bilateral cheminos, I used to put while in England, but in our country we have to adapt the guidelines to our situation. And of course, applicability to the patient. And sometimes the patient may not desire. I cannot force a halo fixation on somebody who doesn't want it. I might as well have a Philadelphia collar or something similar. Then you ask me, why evidence-based medicine? Because evidence is the state of the literature that we discussed since yesterday, which helps clinicians make important decisions in the care of patients. We always want to be better. We want to be better for the patient's sake. And recommendations, of course, made cannot exceed the strength of the literature. So we are as good as literature, except the whims and desires of some clinicians, which nowadays is probably going to minimum because of the legal implications, etc. And where there is a lack of evidence or disagreement in the literature, strong recommendations conditions cannot be met. I think we all understand it. Now, these are the points in the guidelines of cervical spine injury management, which has been very well described. In fact, we are referring to the same study of the Joint Committee of AASNS and CNS, and I will also speak to Dr. Peter Riley about it later, that whether they also follow this as a part of AASNS. But these are the points that we have discussed, and first thing is pre-hospital that Dr. Riley and all of us know about, and immobilization in the case of spinal trauma. And of course the transportation, don't lose any time. Take the patient to the nearest available specialized center. Clinical assessment, it is very important. Of course, Dr. Ganapati very nicely showed about the telemedicine, but clinical assessment, hands-on, is of course very important to see the ABC and all the rest. Radiographic assessment, initial close reduction of fracture dislocation that we all follow. And the cardiopulmonary management is very important, and of course the pharmacological therapy. Other than supporting the cardiovascular, there is not much in the form of pharmacology therapy at the moment. We don't have evidence. And the SLIC system, which I will say that in the due course of my lecture. And of course, the treatment guidelines, whether you operate, you don't operate. So SLIC, the cervical spine injury classification, does help the surgeon to decide or to guide whether you should operate or not operate. Because we see patients in emergency, and some of us will say operate, some will say not operate. So we have some guidelines. And of course, the other DVT prophylaxis, nutrition, and the most important, last but not the least, is rehabilitation, where I think we need all types of help in rehabilitate a patient who has been cured during the hospital stay to get back to his own work, family, society, etc. Now, this is the guideline from the 2013 neurosurgery joint committee, and immobilization is very important in especially cervical spine and as well as the rest of the spine. But it is very important as long as the patient reaches the hospital. After that, what happens in the form of definitive management, you can take the immobilization off if there is nothing, no injury. And this is basically for safe extrication and transport. All the ambulances that we ply in the city of Calcutta and Jamshedpur and Ranchi, they have paramedics, they have oxygen support, they have portable ventilators, ECG monitoring machine, and cervical collar. So that is very important. You should have your paramedic ambulance fully finished. The immobilization is not advised, especially in penetrating injuries, because of obvious changes which can happen. And I might tell you that cervical collar could also be detrimental, especially if the person has head injury. It can raise your ICP if you too tightly compress the jugulars. The various levels of support or recommendations, we all agree that expeditious and careful transport to definite care of medical facility is important. There is no denying that. And ideally, it should be the trauma centers that we all talk about it since yesterday, and I'm sure this will go on in the process of discussion to get the government doing trauma centers in most medical colleges and of course private setups. Neurological examination, ACS score, spinal cord independence measure, the recovery phase with the self-care, respiratory sphincter functions, and the mobility with a score of 100, 20, 40, and 40. And of course the pain, a very important factor in spinal injury. This is the ACS score that we discussed. And I think most of this recommendation has been very well illustrated by Dr. Yu. So I just want to summarize in saying that in the awake asymptomatic patient, if you find there is no complaint, no symptoms, you may not continue the immobilization. But initially, everybody japs a collar on the patient's neck. And also, we discussed about it that the helmets, the motorcyclists or the bicyclists, of course, they don't use it. Motorcyclists use should be a proper helmet that covers your neck as well. It's like a helmet as well as a collar, not the ones they go on the top of the head only, covering the vertex. It should also involve the cover the neck, and that is the whole idea. And awake patients who have neck pain, You need three-dimensional X-rays, three-view X-rays. Best is a high-resolution CT. If you do not have a CT, obviously you go for the X-rays, epilateral and odontoid views. But once you have a CT, or if the patient is stable, you can get the CT. Because many times, like we showed, Dr. Yu showed in his, many times if you do not see the C71, especially for the residents present here, if you do not see the C71, do not accept the cervical spine X-ray, say that you need more views or a CT scan. It is very important. Many times we miss it. And of course, we can continue discussing the X-ray and CT scans, but as I said, high-resolution CT scan is the best, and sometimes to assess the anterior posterior elements of the cervical spine as far as bony elements are concerned. And of course, MRI will give us, there is no denying that MRI will give us more information about the spinal cord, the discs and the soft tissue and the ligaments, and that is very essential, preferably done within 48 hours of injury. And of course, many cases we do straight away if the patient is stable. If the patient is not stable, we stabilize the patient. So we all agree with this guidelines from this joint committee CNS, AASNS. And of course, once we find that everything is normal, we discontinue the collar. Now, again, the CT is very important, and high degree of suspicion and high resolution CT scan are the best in the guidelines. And of course, the patient is unconscious, you don't need a flexion extension. That doesn't really help. But as soon as the patient is stabilized, you get the MRI and then the dynamic X-rays to rule out any obvious subluxations. And the tractions. Now, the craniocervical traction is important if the patient has definite evidence of if there is double injury. And of course, MRI again gives us more information, and especially disrupted herniated interbursal disc, and which is there in about a third of patients with facet subluxation injuries. Now we'll come to the classification shortly, and this is very important that we maintain the good mean arterial blood pressure in spinal cord injury patients, and mean arterial pressure of 85 to 90 is recommended. And again, I will re-emphasize the role of methylprednisolone, not to use it even if the patient arrives 4 hours or 8 hours. These studies, NASIS 1 and 2 and 3, because there are a lot of reports of class 1, class 2, and class 3 evidence of harmful side effects, including death. And Shingen, of course, it's not available here, so we don't use it. Now, the SLIC, which is the subaxial cervical spine injury classification, and the severity scale from 0 to 100, gives us the morphological, ligamentous, and neurological information about the patient. And this second one mentioned is a little complicated, the cervical spine injury severity score, CSISSS. So, coming to SLIC, as I said, it is based on the morphology, the disco-ligamentous integrity, and the neurological function, and in fact quantify the stability and the management guidelines, and is easy to use. So I'll show you a chart of the SLIC very soon, and here if the score is 1 to 3, usually the treatment is conservative. If it is more than 5 or 5 or more than 5, usually the treatment is surgical fixation. So 4 is this way or that way, depending on the other factors. Now this is one SLIC score system, and the letters are small. I wanted to put on one slide, but you can see the morphology from no abnormality to the rotation translation, so 0 to 4, and disco-ligamentous complex, or the DLC, from 0 to 2, and the neurological status from 0 to 4 can be added together to get the total score and the severity. These classifications, coming to the classifications, other than the SLIC, the Harris, the Allen, and many such mentioned, they are usually a little bit complicated. Just to show you before we embark on the classification, what are the normal bony and ligamentous structures possible to actually guess in a plain X-ray. So the anterior longitudinal ligament, the posterior longitudinal ligament, the capsule of the facet joints, the ligamentum flavum, interspinous ligament. Even looking at plain X-ray, you can say that there is disruption of one or the other structures. And these are the different classifications of the SLIC. compression, burst, distraction, translation, rotation. Some pictures showing the CT scan and MRI. The same here from, this is basically from the other classifications, flexion, rotation, extension, compression, shear. I mean, we do that every time we see a case. We have our own standards, fracture dislocations, with or without neurological compression, anterior, posterior, but unification, like SLIC, will help us in having the uniformity of treating them, assessing them, and reporting them to form guidelines in due course of time. So these are the other classifications of Allen classifications, again, showing the different types of injuries. And I go to the next one, which is again one of the other classifications of Allen, showing the bony structures from mild to serious. And again here showing CT scans and MRI pictures, again from Allen's classification, showing the destructive flexion levels of injuries in that. Now, I'll just skip through the rest of the Allen's classifications because it's a little bit complicated, and we will stick to SLIC, but these are the pictures showing the different levels of translation injuries of the cervical spine, and the MRI showing the spinal cord, extent of damage of the spinal cord in the MRI sagittal views. And this is sagittal reformatted views showing the destructive extension stage 2 again of Allen. So we'll just skip through. Now, we have read about White and Punjabi's stability checklist. Some people do refer the above points, starting from the anterior elements, posterior elements, relative sagittal plane translation of more than 3.5, or a rotation translation of more than 20 degrees at 20%. And also, so these are the values, and cord damage, root damage. So total of 5 or more makes the spinal instability. And of course, the translation of more than 20% of the anterior posterior diameter of the involved vertebra make it unstable. So this is White and Punjabi. And this is Anderson's. I'm just showing you different types of classifications people adopt, and the motion segment, parts of the motion segment. So anterior, posterior, left and right lateral. And we all know the Dennis 3-column anterior, middle, and posterior. So coming to the treatment part, which is of course the most important, apart from the pre-hospital, the treatment is that if there is a fracture dislocation, reduction is very important. And of course, decompression of neurological structures, may it be spinal cord or the root, and then stable immobilization and or fixation, both internal and external. And of course, depending on the pathology or the anterior posterior elements involvement, you can either do anterior posterior fixation. In every case, you have to decide which one to do, or you want to do 360. And of course, patients who are moribund and they have surgical problems or multiple medical problems that doesn't allow you to fix the spine, then you can put them on prolonged traction, which is of course you know that very well. And one special note about ankylosing spondylitis is that even if there is minor trauma, people advise CT MRI scans because the spine is very brittle, and we all have handled ankspond patients. Now here, the one caution also is that anterior fixation only results in more than 50% of failures. So you can get away with doing only posterior, but if you want to do, better to do anterior and posterior. Just anterior is not good enough in ankylosing spondylitis patient. This is again the guidelines. So the management, intensive care, we know that. Medical management we discussed. Early reduction, we all agree. And surgical decompression, as I mentioned, could be anterior, posterior, whatever the compression is, and depending on the parts involved. Now, the CT scan in children. This is a pediatric spine injury. Dr. Mahapatra and all our seniors, my colleagues who are interested in pediatric brain and spine injury, there are different set of dictates, different set of guidelines. Now, the CV junction injuries are more prone, or at least you have to rule out, to remember that the less than 7 years, the odontoid synchondrosis is there, and image is recommended in some cases is not recommended. If the child is well, there is no neck pain, no severity of injury, you may not image, because again, imaging children with MRI requires sedation and can have complications from the sedation. Of course, nowadays, different imaging modalities like digital optical scanning or DOT, digital optical tomography is coming, but not adopted worldwide. This is basically a research tool. And the C1, C2 is very important in children, remembering the nature of the injuries, etc. Now, epilateral flexion extension, depending on the case, MRI, this is continuing pediatric. And again, very difficult in children to put halos or tractions. So there, each case has to be individually treated, and especially the atlantoaxial rotatory fixation injuries, they're very tricky to manage, in fact. And the operative intervention in children's spine is little less frequently done compared to the adults. But then if the non-operative treatment fails, you have nothing else but to operate on them. Difficult to know what to use, which material to use, what implant to use, and what happens when the spine grows. Now, SIORA has been discussed. MRI of the whole spine is indicated. Also flexion extension to rule out ligamentous injuries resulting in subluxation dislocations. And external immobilization, if advisable, up to 3 months. And trying to avoid the high risk or contact activities up to 6 months is ideal in SIORA. Vertebral injuries, artery injuries, of course, CT angio is good enough nowadays. But if not available, then catheter angiography with Denver's criteria fulfilling is essential. Of course, MRI has to be done to rule out neuronal injury in addition to the vertebral artery injuries. And the DVT prophylaxis, again, low molecular weight heparin, and wherever possible, pneumatic pumps, SCDs, or stockings even. Only anticoagulation is not effective. That's not recommended. Only heparin is not recommended. And of course, if you have a VTE then or PE, treatment is at least 3 months of anticoagulation. I will just skip through all the other modes of diagnosis of DVTs. And again, this has been properly, although the enteral nutrition doesn't really change the ultimate neurological outcome, but it is very prudent and reasonable to think that as soon as the patient starts eating, he or she should have enteral nutrition. Some of the examples, some teardrop fractures of the vertebral bodies, and of course hangman fractures, I think Professor Kaila will mention shortly. And these are some cases, some old and new cases. Basically flexion translation with the Pertz facets. This is pre-op on your left and intra-op in the middle. You see the under traction, the dislocation is partly reduced. And then we do anterior fixation. That time we use a bone graft to the plate and screw, and a nice fixation, good result. Now MRI showing two vertebral body involvement and cord compression. We go from the front and we fix with the case and plate complex with bone graft in the case. And then double level. I mentioned about double level. So here the traction is detrimental, because you don't know what is happening to the lower level. So we had to put two sets of, not put a long one because the intervening segment was intact. And this patient was an astrologer. And after he got better, he also had severe head injury. He got better and used to tell me my future for the next year. So I used to call him for my follow-up, and then I'll show my hand. So what is going to happen to me next year, he will say. The astrologer. This is the old case, 2-3 dislocation with anterior and posterior. That time we were using these softwares. We did not use C1, C2 that time. After Atul showed us the rest of the world, now we occipital fixation, skull-base injury that Dr. Kaila will tell us. This is standard fixation we do. Cervical stenosis associated with cord contusion or central cord syndrome. But let me tell you that only laminectomy is not the treatment for spinal injury, not even for a degenerative spinal injury. If we do multi-segmental laminectomy, it is ideal or usual or advisable to fix with a lateral mass fixation, and both epilateral. And of course, this picture I really like. This is taken in Singapore. There was a conference. I think Albert Roten, the late great Albert Roten, was taking a lesson in one of the workshops, and we attended one evening. and this gentleman is serving Chinese tea. If you look at the this one, this is actually the kettle. I just want to show you. This is the kettle, and this whole long thing. Even if it looks complicated, you can still do it with precision. But to gain that experience, you need to go through the rehearsal, and especially this message is for my resident colleagues. You need to do the hard work and go through the experience, the good experience from learning from everybody, both senior and junior, to do an act which looks complicated but achieves the result that you want to in a style. Thank you very much. Jai Jagannath. I'll take this opportunity to thank my friend, elder brother, Brigadier Dr. P.K. Sahu, and of course, my big brother, Professor Kuwar here, to have invited me for this lovely occasion. Thank you very much. Jai Jagannath.
Thank you. Nice illuminative lecture. And we will, any question for Dr. Tripathi from the audience?
Pradip. Professor Sahu.
Professor Sahu.
Sir.
In ICU, one sister asked me, sir, this is a patient of spinal cord injury, quadriplegia. What position will you put the patient in the bed?
So, yeah, very important. ICU, of course, we, in addition to the collar, we need to have the air trace. And then turning every 2 hours, a classical teaching of postgraduate, level. So, collar or traction, whatever you got the patient on, and then changing every 2 hours. So, nursing care is very important. Nursing care is very important. And like I mentioned about, if you have a head injury and spine injury, the collar can be detrimental. So, you must release the collar in between. Now, if the patient is bedridden, unless there is a frank dislocation and patient on traction, you can release the collar in between. He is not going to go anywhere if he is unconscious. If he is conscious and not cooperative, that's the problem. And 2 hours is minimum, or sorry, maximum to turning in bed, sir. Skin care.
Thank you, sir, for an excellent presentation. And this is a very simple doubt I want to clear from you. As you have mentioned in the class 3 evidence that if a patient is awake and asymptomatic, there is no need of a imagology.
Yeah.
I have an experience of a patient who has a simple head injury, and we just did the CT scan and he has no complaint.
Do you do dynamic x-rays?
No.
Flexion extension is important. If you have any doubt.
No, there is no symptoms at all.
Correct.
So, we just did a CT scan and see that everything is fine. So, but after 10 days, he came with a complaint of neck pain.
He didn't fall again?
No.
Okay.
And we got an X-ray down to have astonished that there is hangman type of fracture.
Okay.
So, my contention of speaking is that even if patient is awake and asymptomatic, whether it should be do a imagology, simple X-ray or not.
It is very difficult for me to comprehend somebody with a hangman fracture has no symptom at all.
Yeah.
Could be.
Yeah.
Because you had a case, you're right. So this is what I'm saying. This is class 3 evidence. We are saying Dr. Pradip Tripathi had a case that, so this is what I'm saying, that we should write it. You should write as a case report letter to editor, and in fact should write to the CNS, AASNS that I had a case, no symptoms, what should we do? Of course, all of us have experienced anecdotal cases. Yeah. But I'm sure somewhere down the line there could have been some indication, but if there was not, you should report it. But I can't explain it. Thank you.
But for usual practice, it is for any suspected injury or head injury, patient must have extracervical spine. That is our age-old technique.
Yeah, if there is head injury, of course, definitely.
We should not forget that.
Sir, there is a question.
Simple X is important.
Suppose the slick score is 5. We want to operate that. We want to operate that patient.
Sorry, can you identify yourself, please?
Sir, myself, Biswaranjan Naik from Apollo Hospital, Bhubaneswar, sir.
Very good.
Yeah. So, what is the timing of surgery in your protocol, sir? Suppose slick score is 5 or 6, you have to operate. When do you choose to operate that patient?
So, spinal fixation.
Yes, sir.
In spinal injury.
Yes, sir.
very important to understand one basic thing, that the person has to be stable.
Yes, sir.
You don't rush the spinal injury in the middle of the night if person's BP is 60 millimeters systolic, because there is sympathetic injury. Now, unless there is a big compression and the patient in front of you is deteriorating, there is no tearing hurry. So you have immobilized the spine either with collar or traction, and you treat the patient as soon as he is stable, then only you operate. Don't rush in spinal injury, never.
Okay, but there are a few literatures. There's a status trial just published 2 to 3 years back.
Yeah.
Spinal surgical timing for spinal cord injury studies
Very
trial.
good. Yeah.
By Failing Setter. And we have study from AIMS, Dr. By Gupta.
Yes.
These are very large studies. They told that we should operate as early as possible.
Correct. But not in the night. So stabilize the patient. I'm not saying that leave it and forget it and go for holidays. No.
Okay.
Stabilize the patient. Whenever the patient is stable, if it is an operative case,
Okay.
you do the scoring, then you operate. What else?
Is the spinal shock is a contraindication for surgery?
Right. Very good. Yes. Spinal shock is not a absolute contraindication, but if spinal shock associated with some mechanical compression,
Yes, sir.
then with the noradrenaline support and intensive care support, you may operate on that particular spine.
Okay. Thank you, sir.
Thank you so much. Because it can prolong for many weeks, and many people require some inotropic support. Of course, there will be bradycardia and hypotension, but inotropes will help.
So my question is, as a neurologist, we use methylprednisolone in pulse doses in neuromyelitis optica. That is for 5 days, 1 gram daily. And that is recommended also. For you, in spinal trauma, you do not advise steroid.
Sure.
And you said the stage 1, stage 2, 3. FDA denies that to do harm. What harm it does, and why these things are prescribed so randomly? You can enlighten us so that
Yes.
we also we can say that don't give steroids also.
So traumatic, thank you very much for support. Traumatic spinal injury is different from myelitis. And of course, when we operate on intramedullary tumors, we use methylprednisolone. Now, traumatic spinal injury, the damage is instantly at the time of the accident, and it has been shown in many references in many papers that if you give the methylprednisolone, it inhibits the reparative process. So whatever good was going to happen, it stops the reparative process from happening. And there is class 1, class 2 evidence, and some cases also because of very high dose, and in addition to your GI upset, the stress ulcer, the patient have died. Patients have died. So with a little bit of some class 3 reports, there was a lot of criticism, and now in US, no one uses methylprednisolone.
So, like head injury, in spinal injury, steroid
Correct.
indication gone.
Correct. Absolutely, sir. Thank you.
Okay, thank you.
Thank you so much.
Dr. Tripathi. I would invite Professor Kale, and he will speak on thoracolumbar spine injury, guidelines and evidence-based medicine. Dr. Kale is professor and head Department of Neurosurgery, AIMS, New Delhi. Dr. Kale, please.
Good morning, ladies and gentlemen. My thanks to the chairman for giving me this opportunity. Thanks to Brigadier Sao. We go back a long way. 17 and 7, 24 years. But this is the first time I'm coming to a meeting organized by Professor Sao. Thank you very much, sir, for this opportunity. So let me straight away cut to the chase. I think a lot has been said about the spinal cord injury management already by 2 or 3 speakers. So I'm going to skip all that and save it. And let's get down to actually what happens in thoracolumbar spine. So all this has been talked about: immediate care, assessment, investigation, etc., etc. So let's get down to how do you manage, how do you decide when to operate and what to operate, what is going on in the world right now as regards the management of thoracolumbar fractures. So we all know what this is, instability. Basically you want to stabilize the spine. That is one of the goals of surgery. So classification systems. Now the whole thing boils down to how do you classify thoracolumbar fractures, and based upon the classification are the management principles. So a classification system, as you know, has to convey, has to produce a plan, should be able to be used to monitor the patient progress, and then it's a research tool as well. So column injury or cord injury. Now cord injury has been talked about, everything almost has been said and done and dusted, so I'm not going to go with that. Even this, Dr. Tripathi has already spoken about this. What is the two-column classification? This was anterior to the line is anterior, posterior was posterior. And then Dennis came with the three-column classification where the anterior 1/3 of the disc, the body, and the ALL was anterior. The middle part and the posterior part was only the posterior elements. And depending upon what is broken or what is injured, 2 columns or more, definite instability. 1 column you may actually gauge, but still the recommendation was not very clear. Then came AO classification in 1994. Now mostly in the world, the AO classification is used by the orthopedic surgeons. Unfortunately, the neurosurgeons were never quite comfortable with AO classification. So let me just briefly outline what was being done almost everywhere based upon the AO classification. So they classified the vertebral injuries in the thoracolumbar spine into 3 categories, A, B, and C. A is the compression, where the posterior column is intact. B is anterior and posterior column injuries. Now I am talking about columns because we as neurosurgeons are familiar with the 2-column and the 3-column concept. So to translate the AO into the column concept is this slide. A means vertebral body compression, that's mainly the anterior column, while the posterior or the middle may be intact. B, the anterior and posterior column both are injured, with there is some element of distraction. And type C, where there is rotation element also. So that's a very simple way of reducing the AO classification into the column concept, A, B, and C. So A1, A is further subclassified into 1, 2, and 3, where A1 is impaction, B is a split, and 3 is a burst. Now we can actually see what it means. So A is this, where you can see the posterior elements are intact and the body is compressed. A1, there is only one end plate, maybe the upper or the lower end plate is fractured. The disc may be injured, but everything else is intact. By split, that is A2, there is actually the vertebra may be divided into 2. So there's a split. And 3 is incomplete burst. It's still not complete, but it's in many pieces. Maybe half the vertebral body, upper or lower, may be divided into many pieces. Or A3 can be a complete burst, where the anterior and the posterior end plate are gone and the whole vertebral body is injured. Now type B, again, is a posterior ligamentous mainly. B2 is osseous also, and B3 is anterior disc is also disrupted. That means the anterior longitudinal ligament. Again, all the 3 columns are injured. So here is an example. B, that is anterior and posterior element injury with some distraction. B1, you can see that. B2, there is some transosseous element right up to the anterior longitudinal ligament. And B3, there is distraction as well. And C, there is basically rotation. So type A with rotation is C1, type B with rotation is C2, and type 3 with rotation is called a shear injury. So here are the examples. That is the anterior, posterior, everything is fractured. Plus there is some kind of rotation also. So this is type 1, A with rotation. C2 is B, that is a complete split with rotation, and C3, all elements, posterior, everything is fractured. So this was what was being done for type A, vertebral body compression, type B, that is anterior and posterior, and type C, anterior posterior with rotation. What were the treatments available? Non-operative treatment. That is, first one was no treatment, basically just advise and restrict activity. Or spinal immobilization, that is complete bed rest. You don't leave the bed, you use a log rolling, use a lumbar pillow, or there may be some casting or bracing involved, or there could be a combination of all these 3 things. The aim of the treatment was to prevent any neurological deterioration. Now the problem with this classification was that it took care only of the bone. it was mainly a vertebral, a bony classification. It never got into describing the neurology part of it, which we as neurosurgeons were uncomfortable, and mostly patients without neurological deficits would probably not be referred to neurosurgery. Anyhow, so let me get over this. There are some examples of a A3 burst. That is a burst, just the upper end plate is, and so there is some kyphosis developing here. The anterior disc space is decreased. So I'm going to skip all this. This is a stable A3 fracture. So for an A3 fracture, what do you do? What was recommended was bed rest until your patient has a normal trunk control. You do standing x-rays, you make sure that there is no deformity developing or increasing, and then use an extension brace or a cast. Now time, how long do you treat these, or was it recommended? Range for between 1 and 8 weeks, and usually it was 4 to 6 weeks. But it led to complications. There were bed rest sequelae, there were respiratory compromise, worsening of deformity, neurological deteriorations. So then came in the surgical management, and one of the biggest advantage was instrumentation which got developed simultaneously, and the technology which developed simultaneously, which improved results, anatomical results, as well as prevented neurological dysfunction. One of the most important studies which actually talked about fixation of these was a multi-center spine fracture study, which is there in now textbooks everywhere. The Gertzbein Spine Volume 17 has it. And they said that surgery, or the patients who had surgery, had greater percentage of improvement in function. At 1 year, surgical group is significantly greater relative improvement in motor score, and the p-value was 0.00001. And at 2 years, the score was 59% versus 16, and the p-value was 0.00003. So this is the most important, and the Scoliosis Research Society is a very reputed and a very respected organization. And if the SRS recommends, mostly the world follows. That's how important SRS is. So this was the basis of all the spinal fixations which came later. So this was the Gertzbein fracture, and then posterior, anterior, these techniques were developed. The USS system came into being, which was by the Synthes, and you could actually manipulate and correct the deformity, especially in early surgery, where there is still not a well-formed callus. So ligament taxis, they used to call it, and you can correct the deformity. So this came into being for fractures. But, so there were various treatments described for retropulse, if there is neurology, if there is not. So in A1 and A2, it was conservative. In A3, they said if there is a neurological deficit, or if the anterior body height is lost 50%, or if there is a kyphosis is more than 25 degrees, if there is canal encroachment, persistent tenderness, or slow to regain trunk control, then all these things would probably indicate surgery. That was what the recommendation was. So I'm going to skip over all these pictures. Neurological deficit, as you know, it could be complete or incomplete, depending upon that, whether you need to clear the canal or not. If it is a complete injury and there is no chance of recovery, if there is gross violation of the cord, then the chances of recovery are minimal. Type B, difficult to diagnose, but they are easy to fix. Basically, you have to close the gap in the posterior elements to restore the tension band function of the posterior elements. So here are some examples. It requires a simple operation. You do one level above, one level below, a short segment fixation, and it works quite well. And for type C, now here is an example. If you can see in this picture, the upper part of the spine is at one place, and the lower part of the spine, so there is a type C injury. Straight away you can say this is definitely a type C injury. And this was the CT scan, and the cord was damaged quite heavily. So the basic reason of stabilization was so that we could rehabilitate the patient as early as possible. And this was what we did. We actually found an instrument in our orthopedics OT which could distract. After you place the pedicle screw, you fix this instrument and you distract, get the spine aligned. We had great trouble in repairing the dura. We used glue and patches and everything. Finally, the CSF leak could be stopped, and ultimately this was the rest of the operation. As you can see, there is a complete disruption. There is bone missing over there, and the patient had already been 3 days after injury, so there was hardly any chance of recovery because the cord was completely damaged. And this was what the post-op X-ray. He went on a wheelchair. This was many years ago. The date, I think, is 2005. Another example of type C injury, a flexion rotation injury, compression, burst. So according to the AO classification, it would be a type C3, that is a rotation with shear. And so according to the AO classification, this would need surgery. This was the MRI picture of this child. So the TLIX score was known as the SLIX score. There is a thoracolumbar ICS. So again, there is a scoring system involved. I'll talk about that in the next few slides. So this was fixed. We could manage to reduce and align with an anterior reconstruction of the vertebral body with a cage and a graft, and it worked quite well. And after a few months, we even went ahead and removed the screw and rod so that the mobility at the rest of the levels can be restored. And the child did very well. Apart from a foot drop, I think he recovered completely. Timing of surgery, I think the previous speaker and the last few questions have established that fact. So let me straight away get on to what happened with the TLIX. Okay. Now, this one thing I think we should. Now, this was a patient referred from somewhere else after the surgery, and the patient didn't improve. His pain kept on being there. He had already had this operation somewhere else when he came to us, and I just brought up this slide just to point out what's wrong in this X-ray. You know, he probably did not need any fixing. Looking back at his X-rays, he did not need any spinal fixation. He did not need any decompression. There was also a laminectomy done below the screws and above the lower screws. The rods are too thin. If you see the X-rays, the rods were too thin. The screws are too short. The screws don't go to the anterior 1/3 of the body. The screws are too thin. The pedicles are much bigger. He could have probably used a bigger screw. And the screws are in the fractured vertebra, which is dangerous. You should do it only with experience. Otherwise, it's better to skip the fractured vertebra. And the left L2 screw missed the pedicle completely. So all these things can go wrong in spinal fixation. So you must be very careful, firstly, whether it is indicated or not, and then if it is, then the technique has to be good so that you don't make these errors. Your instrumentation has to be matching the size of the vertebra, the size of the screw, the length of the screw, and your direction has to be accurate. So then came the TLIX classification based upon 3 independent criteria. That is morphology, which was based on radiology, integrity of the posterior ligamentous complex. Now this was important, and finally the neurological status. And this was introduced by the Spinal Trauma Study Group, STSG, in 2005. What we did was we went ahead. Nobody had actually done anything with this. It was just a recommendation. It was out there saying that, okay, this is one way to manage. We actually did use this TLIX in management of thoracolumbar fractures after 2011. So we took the patients of 2010 who were not managed with TLIX, and we took the patients in 2011 who were managed according to TLIX, and we compared the 2 groups. And what we found was remarkable. First, let me tell you about TLIX. This is the scoring, injury morphology, whether it's a compression, burst, translational or rotation, or distraction. And neurological status, intact, nerve root injury, cord or conus medullaris, whether it's incomplete, complete, or it's a complete chorda equina. And the posterior ligamentous complex. Now looking at the PLC means an MRI is probably mandatory, because if there is not much neurological deficit, there is no other way of finding out except doing an MRI. So if the PLC is intact, the score is 0. Some injury 2, and if it is completely injured 3. A score of more than or equal to 5 suggests operative treatment. Less than 3, conservative. 4, it's left to your clinical judgment. It could go either way. He may need stabilization, he may not need. So things were much clearer and things were much simpler after TLIX. And what happened to us or our patients, this is the thing. Almost 100 patients in 2010 without TLIX, 100 patients in 2011 with TLIX, and this is the comparison of the 2. So the level of fracture, mostly between D11 and L2, so the typical site of thoracolumbar. Frenkel grade, at the admission we used Frenkel grading, and this was the grading of Frenkel according to the classification. Management comparison, well, without or with TLIX, more or less it was equal. Equal number had operation and equal number did not. Now, comparison of outcomes with and without TLIX. If you see, when TLIX was not being used, 14 did not improve. While TLIX was being used, or amongst the previous years where by chance it happened to fall into the criteria according to TLIX, the improvement rate was 68.26%, not improved. And 53, that is 31.74% actually improved compared to 0. So TLIX actually made us recognize those patients who could benefit with surgery, and the improvement rate was thus, the outcome was better when we used TLIX. So this is just a graphical representation of the same thing. Again, 2010, 99 patients had surgery, while in 2011, 89. In spite of 10 operations less, the outcome was better. That means we could identify some patients who did not need surgery. Now this is important. You can identify patients who do not need surgery based upon TLIX. So these are the two most important things which we could gather from our own study to validate the TLIX, that you can bring down the number of surgeries, you can bring down the number of unindicated surgeries, and the outcome is definitely better. A couple of examples: a 24-year-old male, he then went on to have a long fixation and he did very well. A few more examples. L1 fracture, TLIX score of 5. Stabilized, did well. Again, a gross distraction, type C, C3 kind of an injury, terrible injury. But with the present systems available, we could reduce that with distraction and get him aligned. Unfortunately, the neurology did not improve. So to conclude, it's either the AO system in the old, which uses only morphology, or it's the TLIX system which is new. We are one of the probably the first ones, because I was part of the AO study group. We were one of the first ones to try and validate this TLIX score, and it worked for us. It decreased the number of surgeries and it resulted in better outcome. So still it requires vigorous validity and reliability testing, and as our understanding of these fractures and the neurology associated with it improves, maybe it may get modified over the next few years, but we are welcome, we are open to change. So I would recommend from the institute, that's what we follow. We follow the TLIX system for management of thoracolumbar fractures. Thank you very much for your attention.
Thank you, Dr. Kalia, for your excellent presentations. Now it is open for discussions.
Yeah, please.
Thoracic spine, they all, the leaks are very useful. And exactly, I'm going to do the same for our institute. Look at our cervical spine injuries, putting them in slicks like TLIX. Thank you very much for enlightening. Thank you.
Sir, in cases where there is gross fracture dislocation, like there is fracture of L1 and L1 body is dislocated and just lying behind T12. In those cases, many a times if you put screws in T12 and L2 and do distraction, you may not achieve the total reduction. So what is your suggestion, whether we should go above 1 or below 1, so that the distraction, because in that particular segment distraction, sometimes it is so stressed that you fear that there will be more damage to the cord. And I want your suggestion, whether you electively go for above or below 1 extra.
Yeah, so that's I showed you an example of a horrible thoracic dislocation, and it was D3. So for that we went 3 levels above and 3 levels below, because unless you have 2 or 3 anchoring points above and below, you won't be able to get that power to distract. Yeah, absolutely. All cases.
Dr. Kale, thank you very much. There's a little doubt. When do you decide to put short segment stabilization and long segment? So what is that criteria?
So, I mean, if you go by the system which is there, the AO system, it gives you You know, if it's only the posterior ligamentous complex which is injured and there is some extension, the two spinous processes are farther away and the ligament is torn, and if you need to stabilize, that is the time to use a short segment. Or if there is a posterior column injury according to the old concept, where the ligamentous complex may be injured, or the yellow ligament, or the ligaments at the back may be injured, but everything else is stable, then only a short segment is included. Or in the thoracic spine, if you are approaching anteriorly, you know, there are some cases where you may approach anteriorly, do a thoracotomy. So after doing a thoracotomy, to get a long segment in the anterior spine is not possible. So these are the various limitations by which your choices get decided. But the bottom line is that if you need to distract a lot, if you need to manipulate the spine and get into alignment, you need more than 2 fixation points to get that distraction force. Because the neurology probably in such gross injuries is not going to improve. So the idea is not to improve neurology. Here it is mainly to get the spine aligned so that rehabilitation can proceed at the correct times.
Well, we have seen some patients with short fixation who they don't remain stable. So that's an issue.
Well, so that is why this whole thing, there's still, you know, it's not very clear. The literature doesn't say that there are clear-cut guidelines to how to manage. So the AO system was there, which was based only on morphology, but then again it had its drawbacks. Neurology was never considered, and that's how the TLICs came into effect for thoracolumbar injury. Even that has not been validated by everybody. It's not accepted as a gold standard. It's not.
Sir, by the McCormick classification, for the long segment and short segment fixation, and whether we have to fix anteriorly or posteriorly or both, there is a study by McCormick, the 9 scoring system. The score, if the score is more than 3, then we have to do a long segment fixation or both anterior and posterior. If the score is less than 3, then you can go for a short segment fixation.
Yeah, so that is part of the AO recommendation.
Yes, sir.
That what you are referring to has taken into account in the AO. Okay.
Thank you, Dr. Kale, for good presentations and excellent discussions. And I will invite the next speaker. Thank you.
Next speaker is Dr. Namkyu. Yeah, Dr. Namkyu, please.
This time I'm talking about the spinal cord injury update on clinical trials and biomarkers. This is the contents, the clinical trials and clinicaltrials.gov, and ongoing clinical trials in spinal cord injury and previous study result about the trials. And then biomarkers in spinal cord injury that I will talk. Clinical trials are the experimental or observational done in clinical research. Such prospective biomechanical or behavioral research studies on human participants are designed to answer the specific questions about biomedical or behavioral interventions, including new treatments, such as novel vaccines, drugs, dietary choice, dietary supplements, and medical devices, and known interventions that warrant further study and comparison. Results of clinical trials will be used in revised or re-establish of clinical guidelines in spinal cord injury. Clinicaltrials.gov is a resource provided by the U.S. National Library of Medicine. You can connect it free via internet. You can search registered clinical trials you want to know. So I searched the clinical spinal cord injury in clinicaltrials.gov. Registered trials in clinicaltrials.gov about the spinal cord injuries, 854 studies. And in of them, interventional clinical trials is 700 studies. From 2010 total 465 studies were registered. And in that clinical trials, that is divided interventional and observational clinical trials. In interventional clinical trials, there was drug, and stem cell transplantation, and devices and training. Currently ongoing clinical trials, that is about drug, there selected some recently and famous drugs. Neurological in US, phase 2 and 3 trials is ongoing. And minocycline, Canada and Australia group is also recruiting an ongoing study. And other drugs has not yet commercial name, but just have the initial materials. And biologic study was also done in China, for transplantation. So this is the phase 1 trial result of the Neurological in spinal cord injury. It is published in 2014 Journal of Neurotrauma. So very small, but including criteria is age over 18 and below 17 years old, and the patient who written an informed consent in this study. So trauma level is from C4 to 10. T11, and AIS grade is A, B, C. And exclusion criteria, there is a lack of the informed consent and other contraindicated to Neurological in administration. So this is the result of phase 1 trial of Neurological, and all patients who received Neurological was well tolerable, and there was significant some improvement in motor score. So Neurological may have a beneficial effect on motor outcome in cervical spinal cord injury. So the phase 2 and 3 study is now ongoing. And about the treatment, hyperthermia and induced hypertension, CSF drainage, and blood pressure control, epidural decompression in early phase, and intermittent hypoxia is now ongoing clinical trials. And additional about the supportive care, zoledronic acid and other medications for spinal cord injury was now still ongoing. And this is some basic study about the hypothermia in spinal cord injury. The authors did the hypothermia in spinal cord injury model of rat. So they compared the motor function and the sparing of injured spinal cord tissue. Upper graph showed the improvement after injury. So spinal cord injury plus hypothermia treatment showed more rapid recovery and more than recover in some day of the survivor. And lower pathologic slides showed that upper row is the spinal cord injury only, and lower column is the spinal cord injury with hypothermia. And there is more preserving of spinal cord tissues in hypothermic groups. And so that many animal studies done about the spinal cord injury with hypothermic treatment. So this this is the animal study, but most of them showed the clinical motor improvement and preserving the spinal cord tissue in animal study. So animal study. So now hypothermia in spinal cord injury in human is clinical study is ongoing now, and hypoxia, intermittent hypoxia is already already done in human patient, and it is published in this year in Journal of Neurotrauma. So the investigator did intermittent hypoxia with training, 9% O2 oxygen, and then 21% O2 every 1.5 minutes, and then 15 cycles per day. So they reported that more improvement of motor working test in intermittent hypoxia group. So, and vasopressor use, also studied and published in Journal of Neurotrauma 2014. So we spinal cord injury patient suffer from hypotension because they have also underwent the experienced spinal shock and neurogenic shock. So we also many times use inotropics for maintain blood pressure. The most common used drug is dopamine and phenylephrine. So in this report, dopamine and phenylephrine increase the risk of some complication, especially in dopamine infusion patient. And also without the hemorrhagic shock, the hemorrhagic shock patient was excluded. Also showed some. Excluded the hemorrhagic shock patient. Dopamine and epinephrine showed the relatively low risk of complication. So also this is the ventilator set using patient. High tidal and standard tidal volume is affect about the weaning of individuals. So in this study, from ideal body weight, about ideal body weight, so higher tidal volumes means 20 milliliter per kg, and standard 10 milliliter per kg is tidal volume. Finally, they found that no harmful effect in high tidal volume patient. And now, still hot issue is the stem cell transplantation in spinal cord injury. And I found some spinal cord stem cell therapy in spinal cord injury in India, but I don't know about where or how. And another umbilical cord mesenchymal stem cell transplantation is ongoing in China. And so mesenchymal stem cell transplantation is not only in spinal cord injury, and any other diseases, and they want the paracrine effect. The transplanted stem cell will effect on paracrine effect and neuromodulation and other treatment, other killing of the injured cells. So this is the proportion of the disease. Total 493 mesenchymal cell-based clinical trials. The neurogenic disease is the 87. And in that 87 neurogenic disease clinical trials, spinal cord injury trials was done in 25 clinical trials. But the mesenchymal cell stem cell transplantation is only done in phase 1 and 2, not in 3 or 4, because currently we are doing the safety and efficacy of mesenchymal stem cell based therapy. So again, the stem cell is stem cell will differentiate in injured area and help remyelination and produce neurotrophic factors, and some stem cell will differentiate the neuron and produce extracellular matrix and reduce glial scar. And biologic scaffold enhance this stem cell function. And clinically, the stem cell transplantation is very dangerous because we stem cell transplantation via surgical procedure. And some investigators reported about the chronic stem cell transplantation in chronic cervical spinal cord injury and functional outcome measurement at 12 months and as a phase 2 clinical trial. And this is another study, and it is the intramedullary transplantation of stem cell therapy the measurement of safety. And it is not yet published paper, but electronically published. So exposure of dura and check the intraoperative sonography with cavity lesion, and then insert very small cannula needle, then infusion of the mesenchymal stem cell. So upper A, B, C, D is the preoperative MRI. Pre-transplanted MRI showed the high signal in spinal cord above and below the spinal cord. And later, about 3 months later, post-transplanted MRI showed decreased the high signal intensity of spinal cord below an injected area. And sometimes, in some institutes, they use the special fixation kit to reduce the additional spinal cord injury during the stem cell transplantation. And medical devices using clinical trials is ongoing. This is for chronic patient, and robotic device such in this picture is more helpful for paraplegic patient, because and more severe case, quadriplegic patient, brain-computer interface and spinal cord computer interface is now on study. So they call it exoskeleton, and for paraplegic patient because the main function is working and needs some balance control for their arm function. And this is the case of brain-computer interface. If you search the brain-computer interface, you can find this picture very easily, because the patient has, I remember that the brainstem stroke, so she is quadriplegic. And investigator inserts the coin-size sensor on her motor cortex, then detect the signal of the motor cortex and decode that in computer, and she control double arm. So she can eat or holding cup and draw picture by her thinking. And this is conceptual image. So in spinal cord injury patient, we also use the electronic sensor and electric stimulator above the injured level and below the injured level, but not yet clinically applied. So there is other observational trials, the mainly registry trials and biomarkers of spontaneous recovery and longitudinal examination of aging. And after surgical treatment, the prognosis of spinal cord injury trials are also ongoing. And now I talk about the biomarkers. Neural tissue damage causes release of several cellular specific proteins and induce increase of inflammatory proteins. In traumatic brain injury, biomarkers in serum or CSF are used for diagnosis and predict recovery and outcome. Biomarkers in spinal cord injury are also same role of traumatic brain injury. This is the simple picture about the spinal cord injury. Initial trauma caused the release of CNS protein into CSF and bloodstream, and release cytokine and chemokines, and that activated the immune system, and immunity caused the increase of the lesion. And there are structural inflammatory biomarkers and another several antigen selection or some other materials. But now the well-known biomarkers is the first structural and functional biomarkers. NSE, neuron-specific enolase, and tau, neurofilament, S100 beta, GFA, PGFAP, and myelin-based protein, SD alpha-2 septrin breakdown product, UCHL1, is already used in traumatic brain injury. And inflammation-related biomarkers are interleukin series, monocyte chemo-attracted protein, MMP9, CXCL10, icosanoid, and tumor necrospector. So, investigators reported the possible biomarkers in spinal cord injury: S100 beta, GFAP, MVP, and I already showed the graph in previous image, previous page. So I found one clinical research of the biomarkers in spinal cord injury, and Brian Guan, who is working in Canada, reported the cerebral spinal fluid biomarkers to stratify injury severity and predict the outcome in human traumatic spinal cord injury. So this graph showed each biomarkers correlate with the prognosis of recovery of AI score, and red dot means AISA, blue square means ASB, and triangle means black triangle is AIC. So all patients, including cervical and thoracic patient, interleukin 6 and tau, S100 beta, GFAP is different in each group. It is the initial within the 24-hour level of the biomarkers, and cervical only patient, interleukin 6, interleukin 8, tau, and S100 beta, GFAP also, and sigma difference. But thoracic patient, interleukin 6 and GFAP, GFAP is different. So this is ROS curve. Area under the blue and red line is more than 0.8, 95% CI. This result showed the high degree of discrimination, and all markers could be reliable markers of an AI's improvement. This is a result of linear discriminant analysis. All patient and cervical patient prediction rate was 83 to 86%, and same in cross validations. But thoracic patient, 94% in linear discrimination, and cross validation is increased validation 77%. This is conclusion page. Clinical trials, there are so many clinical trials ongoing in spinal cord injury, and they will be the evidence of future guidelines. So high quality randomized control trials, the result will be the class 1 evidence of the guideline. And biomarkers is the more hard issue in investigators. It is useful for diagnosis spinal cord injury. I think especially in spinal cord injury without bilateral abnormality, and assess the severity of injury. And finally, we can use it predict recovery and prognosis. Thank you.
Thank you, thank you. Now the topic is open for discussion, as we have time 5 to 7 minutes for second session. The 10th session, I think after that. We can take few questions for discussion. Yeah, Dr. Tripathi.
Your comment.
Professor Mahanti.
Ideally, when there is a full transection or partial transection of the spinal cord, the neuronal graft or the stem cell will be the best choice, because if they establish the connectivity above and below, then the functional recovery is likely to be depending on the injury. We have some experience with neuronal graft. This was one Indian who was working in USA. He has been almost a full-time research on the spinal cord injury and neuronal graft. He came to All India Institute of Medical Sciences sometime in 70s and held a workshop in which he used to transect the spinal cord of the rat, and then soon after he used to implant the fetal neural tissue into the graft, and he closed the wound, and after some time he used to study the neurological recovery, and it was not very successful, but there was evidence of some partial. And we have tried in some cases the stem cell in our hospital, and this is also not very encouraging. The question is that when we neural tissue, said that there is exclusion of that graft by proliferation surrounding the, so it almost behaves like a small neuronal tumor inside the spinal cord. It does communication above and possibility because of the dense gliotic scar. So the possibility will be in future that if you can prevent the glial scar formation, perhaps the neurons will be able to connect the above and below the injury. So that will help in the recovery. So the research in this case will be more towards preventing the glial scar formation along with the neuronal graft or stem cell. So this is a sort of comment I would like to give.
Yeah, Dr. Tripathi.
You are infusing the prepared stem cells into the cord substance.
Pardon?
You are infusing the prepared stem cells into the cord substance at the site of injury.
Infusing, putting the stem cells inside the spinal cord.
You mean direct injection of the stem cell in spinal cord?
You are doing that. You have shown that. Are you doing that?
Yeah,
or
I have experience when I'm training. I was the clinical fellow of the institute. My professor doing that. He used some special syringe pump.
That's fine. My question is that if you go through the literature, and we have an experience also, Professor Mahanti, who has mentioned stem cell. Usually what we have done, we infused the prepared stem cells into the subarachnoid space at below the site of injury, not into the spinal cord substance.
You mean location of the injection?
Yeah.
We did 3 locations. In my experience, just above the injured level and injured cavity, also below the level.
No, that's my question is that only, whether it should be given into the substance or it should be given to the subarachnoid space at the site or below the site of the injury. That was my question.
Yeah, Professor
The recommendations are, suppose we have done 50 cases of spinal cord injury, cervical, thoracic. Of course, in cauda equina region, there is no need of giving any stem cell, neither that is going to benefit. So in a cervical spinal cord injury and thoracic spinal cord injury, if you are operating that case, then when you are operating, you are stabilizing. In that situation, as rightly pointed out, it has to above, at the site, and below you have to inject. But cases, those are chronic cases, if you are trying, or cases those are not being operated, of course, those cases you should not open up to inject in spinal cord, and you have given the subarachnoid space. So the preparation, everything same, but in our study you found it is safe, it is feasible, but we have not found any cases those are improved by giving stem therapy, particularly the A and B type, they have not improved, they remain in the same stage, they have not improved in our case. In spite of stabilizing, decompressing, we found they have not improved. But what I'm saying, when they say certain patients they improve by doing stem cell therapy, they have not assessed them properly whether it's type A or type B. If you assess type A properly, there is complete loss of motor and sensory, such cases, whether there is a cord transaction, they do not improve in our experience. But it is safe, it is feasible, doesn't cause meningitis, abscess, that has not happened. So it can be given both intrathecally as well as in the subarachnoid space.
So, Professor Aryan Sahu.
All the discussion for last 2 days, nobody just mentioned about the evoked potential, like somatosensory evoked potentials, motor remote potential in spinal cord injury. Can you give some idea whether you do that in a routinely in a spinal cord?
Potential studies, evoke potential studies, like sensory evoke potential. Electrophysiological studies.
During the
To know the site of injury, how much injury there, what are the tracks are involved.
I am sorry,
No,
I'm not
no idea
clearly,
about those. Yeah, Dr. Biswal.
In your stem cell experiment, which type of separator you used for your stem cells?
You mean origin of stem cell?
Yeah, which there are different methods of separation to get the stem cells. So what type of?
There are many sources of the stem cell, but basically, my experience the bone marrow derived mesenchymal stem cell, and also mentioned the fetal cell derived the stem cell is also studied, and I also experienced the autologous adipose tissue stem cell was applied in spinal cord injury patient.
My question to Dr. Mohanty that how, in which method they have separated the stem cells? Because maximum work in India has been done on FICO separation, and there is an institute in Mumbai who is doing it, but the results have been dismal. There has been no improvement seen, at least in spinal cord injury. So, no, I'm not saying that. I just wanted to know which type of separation, so that because it also depends on the type of the stem cell and what you are giving. The majority of the work which has been done now has been mostly like what Dr. Sahu said. When you are operating during the time of the surgery, you implant it at the site, above and below. That is the best time. If it's a new injury, you are operating. In old cases, just go for an intrathecal, but the results are very poor. Right.
Yeah. Dr. Mohanty will got that? Yeah. Professor Mohanty, please. Yeah. If there are no questions, we can close the session. Okay. Thank you. I thank all the speakers on behalf of the chairpersons and close the session. Thank you all.
Thank you to the chairpersons and the speaker. Sir, I would request you all to be there on the dais. I would request Dr. Ellen Tripathi and Dr. S.S. Kale to come on the dais, please. I would request Professor Dr. S.N. Ghosh to felicitate Dr. Ellen Tripathi. I would request Professor Dr. B.D. Lenka to felicitate Dr. S.S. Kale. Now, I would request Dr. S.S. Kale to felicitate Dr. S.N. Ghosh. A humble request to Dr. Ellen Tripathi to felicitate Dr. B.D. Lenka. Thank you so much. Thank you to the chairpersons and the speakers. Now we'll be moving on to the last technical session, that is the 10th technical session, for which I would like to invite Professor Dr. Chaudhary N.R. Nanda to chair the session. Dr. N.R. Nanda has passed his MBBS from SCB Medical College, Cuttack in the year 1968. He did his MS in General Surgery from SCB Medical College in the year 1973. He did his MCH in Neurosurgery from All India Institute of Medical Sciences, New Delhi in the year 1973. He became professor and head of the Department of Neurosurgery Department from 1993 to 2002. He was the medical superintendent and the principal of SCB Medical College from 2000 to 2002. Sir, may I have you on dais, please? A humble request to Dr. Maya Gantayat. She is the Senior Consultant of Neurology Department and Director of Ashwini Hospital, Cuttack. She has passed her MBBS from SCB Medical College in the year 1977. She has done her DM from NIMHANS, Bangalore in the year 1984. She has been trained in electrophysiology from London Hospital in the year 1986. Thank you, ma'am. I would request Professor Dr. R.N. Sahu to come on the dais, please. He is the professor and head of the Department of Neurosurgery at All India Institute of Medical Sciences. Thanks to all the chairpersons on dais. Now I would request the chairpersons to carry forward the session.
Namaskar to all the delegates in the meet. This is the last session, session 10 or session X. I'm sure it will be the last and the best, just like iPhone X. So to begin with, let me invite Dr. S.S. Kale to come and deliver his talk on C1, C2 trauma and complications arising out of surgery for C1, C2 trauma.
Before that, we have a small feedback form which will be distributed to all the speakers, chairpersons and the delegates. I would request everyone to kindly fill up the feedback form and submit to us. Thank you. Dr. Kale.
Good afternoon once again, ladies and gentlemen. Thank you, the chairpersons, for this opportunity, and thanks again to Brigadier Sahu. Let's begin right away. Dreaded complications in upper cervical spine injury surgery. Now, if you see, this is just a synopsis of all the literature published earlier and the publications which talked about complications. Do I have a pointer? Very good. Okay, so if you see the, maybe this is better. So if you, that doesn't reach that. Anyway, if you see that the rate at which the series talked about complications, if you see 2000, 2004, then nothing for 3 years, 7, 8, 9, and then you see a sudden spurt. If you see 11 onwards, and then after 13 I stopped counting. There were so many series published which actually talked about complications. So it could mean two things. It could mean that we are becoming bad surgeons, or it could mean that the surgery of C1, C2 trauma is increasing. So probably that is the reason. as more and more surgeons get trained into dealing with this earlier called no man's land, I think we see more and more complications, and that's what I'm here to talk about. And if you see, the most common 3 complications of this is during stabilization. That is non-union. If you go for fusion, ultimately it doesn't fuse. Second is reoperation. For some reason or the other, you have to reoperate. And the third is malposition of your instrumentation. Your screws getting malpositioned. And these are the 3 most common complications which happen as far as the literature is concerned. And if you see the non-union rates, there is a wide range. Some people have reported from 4%, 5% to 62%. So that's tremendous. 62 means 2 out of 3 patients don't fuse. Then what are we doing? What is wrong with the operation? Or what went wrong in at least this series? And that must be looked at. So we looked at our data, compared it to the world literature. And the literature says range is between 6% to 27% malposition. The malposition of the screw can lead to non-union. Ultimately, it doesn't fuse because your screws are not placed properly. The graft gets displaced, it's loose, and it doesn't fuse. And this is the range in which the world literature has talked about malposition. What about us? Between 2008 and 14, we studied 142 patients of odontoid fractures. I'm going to limit my talk to odontoid fractures and maybe a little bit about hangmans. And we published this series in Neurology India a couple of years ago, in which 85 patients had an anterior odontoid screw and 57 patients had a posterior fixation for the odontoid fractures. What was our complication rate? So if you see, 4 out of 80 patients actually had non-union in our series, which is 5%. Which is compared to the world literature, it's right there. Nothing very dramatically different. At 3 months, the union rate increases to 91.2%. And after 3 months, if you take into account long-term follow-up also, then the overall union rate is 95%. So that's not bad, I would say, considering that it's a huge tertiary trauma care and a lot of people, different levels of surgeons operate at different times. So this is a combined statistic of everybody. That's 23 faculty put together, and all of them probably end up operating on some patient or the other. So considering all that, this complication rate or the non-union rate is quite good. What about mortality? Now that is strange because odontoid fractures will either, the patient won't reach the hospital. You know, many times it happens that the injury is so severe that they're unable to reach the hospital, or if they do, then they usually make it. They don't die, because the world literature says that the mortality is between 0 to 5%, and this 5% is probably due to other injuries which were coexistent in this patient. But in our series of these 80 odd patients, 1% died. That's 0.9%, and it was a neurovascular injury. And we'll come to that. I'll show you the case how that happened. After this publication, I looked at the other patients as well. So ultimately, till the beginning of this year, we had a total of 215 patients who had odontoid fractures, out of which 111 had an anterior odontoid screw fixation, 86 had a posterior fixation, and 18, because of various factors, were managed conservatively. Now here is a case. Intraoperative K-wire breakage while you're making the first entry into the bone. If you see that, one of my young colleagues, he put in a K-wire and he broke. And I got a call from the theater saying that, what am I going to do? There's a K-wire piece hanging inside the odontoid. What do I do? So this was the first time I had faced this problem. So I thought, well, let me come to the theater, let's see. I thought, and I decided that if I have to take that K-wire out, it will mean a bigger hole in the odontoid, and probably then the opportunity of putting an odontoid screw is lost. So I thought, let that K-wire piece be there. Let me try and put a screw just next to that. And that's what we tried to do, and we were quite successful in doing that. In that picture, you can see the broken K-wire and then the second K-wire or the drill which we used to put the screw. And this patient went on to fuse well. In this CT scan also you can see the two, the K-wire and that. So and this is especially for the young ones. If you don't handle the K-wire properly, if your K-wire is old, especially which has been used many times and it has been turned and twisted and bent, this can happen. And remember, you are starting at between C2 and C3 and the odontoid is far away. And if it breaks there, you're stuck. If you try to retrieve that, the opportunity of doing an odontoid screw is lost. So if in your judgment the width of the odontoid is enough to take another screw, just forget about that broken K-wire. Go ahead and put a screw right next to the K-wire and it will work very well. Another case. How people or young people or sometimes surgeons do try to push the envelope. Now if you remember the indications for odontoid screw and more importantly the contraindications for putting an odontoid screw. This CT scan slightly displays type 3 odontoid fracture. Now classically this is a type 3. But my young colleague argued that, sir, there are just two main big pieces and probably this screw will work and I'm going to put a screw. Actually he didn't tell me. He first put the screw and then he told me that, I thought that it is just two pieces, it'll probably do it. But most important thing he overlooked. If you look at the CT scan here, remember that, all the young people, if your fracture line crosses the lateral joint, never put an odontoid screw. If the fracture line crosses the odontoid and the C1, C2 joint, never put an odontoid screw. And that is what was overlooked. He thought, well, maybe I can get away if I can get this piece. The lag effect of the screw will probably bring it back. But what happened? I looked at the X-ray. He says, well, on the table, the X-ray looked fine. Everything looked in place, so I put a screw. And what happened later? At the time of surgery, everything looked fine. But third post-operative day, this is what happened. So this is what happens. If you try to push the envelope, this is what happens. So please look at the CT scan and the X-ray carefully. If it is anywhere reaching the joint, do not attempt an odontoid screw because most probably it is going to fail. And now looking back, if you look at the X-ray, even on the table, if you see there's something wrong over here which has been encircled. This is not a standard type 2 odontoid fracture. There is definite fracture line going into the body. So even if it is a lateral X-ray and you don't have an image which shows the joint, this kind of an X-ray, beware. The odontoid screw is going to fail. So what happened? We had to go from the back. We had to put a C1, C2 transarticular screw. It meant another operation. And finally we could stabilize him. Another case, 25-year-old male patient, RTA, a bike accident, a typical injury to the neck. No other neurological deficits, anterior odontoid screw fixation. Now, okay, if you look at this post-operative picture, there are 2 or 3 glaring problems which you can see in this. One, the screw is too long. The screw head should be buried in the C2 and C3 disc. It shouldn't be hanging out like this on the C3 body. 2, the lag effect of the screw hasn't come. The two fractures, the two parts of the bone haven't come close together. There's still a gap between the two fragments. So most probably this screw is going to fail. That is what was my first impression after looking at the post-op X-ray. And that's what happened. Within a few days, the screw cut through. So if you don't remember, the odontoid screw is a lag screw. Lag screw means only the distal half has got threads on it. The proximal half is more like a bolt. It's smooth. So the distal half which has threads, that engages the distal part of the odontoid and actually it pulls it back, and that's how this odontoid screw works. So if that basic principle of a lag effect is not achieved, it is bound to fail. So that is another place where you can go wrong. Please make sure that you get that compression, you get that lag effect, and you get the two pieces of odontoid together, otherwise it's going to fail. Again, we had to do a second surgery. We had to go from the back and have a midline graft, which you can see over here, stabilized with cables, and a C1, C2 transarticular screw. But what happened in follow-up? This is what happened in follow-up. The odontoid fracture healed, but look what happened below. The patient is falling off at C3-4. We went back and looked at the CT scan and the X-rays. There was a fracture below which was missed. So, odontoid screw is a very nice and elegant and a relatively simple surgery. So the moment you see odontoid, you forget everything else. And this is what happened. The fracture lower down was missed, and this resulted in kyphosis a couple of weeks or a few weeks down the line. And then the patient had a whole lot of problems after this. He got infected, and we had to go from the back, and then we had to put him on halo, and ultimately he had this big surgery which had to be done anterior and posterior, and halo had to remain for 3 months till the infection cleared. Once the infection was gone, this is what he ultimately had, and after 3 months everything settled. And so a simple odontoid screw, in the enthusiasm of putting an odontoid screw, this is what happened. So please don't forget to look at the rest of the cervical spine before you jump into putting the odontoid screw. Another case, 7-year-old child had a traumatic type 2 odontoid fracture. Remember, children, I think Dr. Tripathi mentioned that, and Dr. Yu too mentioned, children is a separate category altogether. So one must pay particular attention. Okay, anyway, so this, my colleague said that, okay, this looks very fine, everything is fine, an odontoid screw can take care, there is no neurological deficit. Okay, I said, fine. Be careful, be careful. I said, yes sir, everything was fine. In surgery, everything was fine. And these are the pictures. The flip side of good technology or expensive technology is that it records. You know, every time you take an X-ray, it gets recorded in the machine. So I looked at this X-ray later on, and I said, well, your K-wire is a bit too high. It's gone beyond the odontoid. Are you sure everything engaged the distal cortex and everything was fine? The post-op, I said, well, your screw is too long. He said, sir, but that's not the problem. The patient is not waking up. The child never woke up. So I got a scan done, and look what happened. A subarachnoid hemorrhage. A subarachnoid hemorrhage in the basal cistern means that the K-wire probably traveled a few inches above the odontoid, and it hit some major vessel in the circle of Willis or nearby that. And this is what led to this. Now what went wrong? Children do not have thick cortices like adults. The distal cortex of the odontoid is very thin in children. So pushing a K-wire, you have to be extremely, extremely careful. Otherwise, this is what can happen. And this child ultimately never woke up. And this is the 0.9% of the single mortality in our series of 211 patients with odontoid fractures. So in our series of 200 patients, 2 patients had a vertebral artery injury too, which was recognized during surgery, out of which 1 was fatal. Now this was posterior approach, so I didn't count it in the anterior odontoid fractures, but there were other fatal injuries as well. Case 5, C2 pedicle screw. Now C2 pedicle screw can be tricky. You may learn, you may look at the pictures, but on the table, a few millimeters here and there, a few degrees of angulation above or below, or medial and lateral, and this dangerous complication can occur. An 8-year-old male, traumatic, reducible atlantoaxial dislocation. He actually fell from stairs. He had neurology. The patient underwent a C1 lateral mass and a C2 pedicle screw and rod fixation. This is what the picture looked like. Left joint and the right joint, you can see what's happening there. This was what the post-op picture. We thought everything was fine. The picture looked all right. However, the patient did not wake up again. On evaluation, there was bilateral vertebral artery injury due to the C2 pedicle screw. And eventually the patient died. He had a massive brain edema and hydrocephalus. The MRI, we got it done. It showed acute infarcts in the posterior circulation. And if you look at this one axial picture, it shows clearly where bilaterally the vertebral artery has been violated, while on the X-ray, everything looked fine. So X-rays can be dangerous. Unless you are very well experienced to interpret X-rays, if you try to put a pedicle screw without much experience and based only on X-rays, it can lead to dangerous complications. That's the advantage of Institute. You can actually document everything. We got an angiogram done. We actually showed that the vertebral artery is knocked off on both sides. And this is the cutoff. We did a posterior decompression. We removed some bone. We did a duroplasty. But unfortunately, couldn't save this patient. A hangman's fracture. If you see this, it's a clear-cut hangman's fracture. So we thought, okay, C2 is dangerous, so let me go 1 above and 1 below. Let me stabilize C1 and C3. It can be done anteriorly, it can be done posteriorly as well. So that is what was tried, a C1 to C3 lateral mass fixation and fusion. And look what happened a few days later. Again, when you see something which has got a very surgically, which is very amenable to your techniques, you miss the rest of the spine. And this is what happened. Again, there was an injury below which was missed, and the patient started falling off below C3. Especially because there was a big huge rod and screws stabilizing the spine C1, C2, C3. So the whole load was being borne by the next disc, which is C3, 4, and it was already injured, the lateral mass was injured, and the patient started falling off. And again, we had to do some major surgery, front and back, to actually get him in shape. And ultimately, this is what was the follow-up scan a few months down the line. So we realized that the C2 pedicle is a problem. And by that time, we had this new gadget which is called the O-arm. The O-arm is as good as a CT scan inside your theater on your table. And so we decided that, okay, C1, C2, everybody is going to use the O-arm. Please do not go ahead and fix these without the use of O-arm. And what happened? Our screw misplacement rate and complication rate went down to 0. Believe it or not, it cost 3.5 crores, but it is worth every rupee. It reduced these dangerous complications almost completely. And this we published, which was published in Spine a couple of years ago. In our series, there was only one grade 2 misplacement, that is 5% of C2 pedicle screw, as per the modified classification of Gertzbein and Robbins. And all patients, 100%, had good fusion, because ultimately fusion depends upon your reduction and the maintenance of that reduction, and that depends upon your screw placement. So, to avoid these complications, you need to plan properly, you need skill and experience, you need a pre-op CT angiography. At least you must have a CT angiography. You must know which side of vertebral is dominant, or are they co-dominant. Screw trajectory and entry points of C2 pedicle screw and C1, C3 lateral masses should be absolutely clear in that given anatomy of the patient, not a general textbook definition, but in that patient, after studying all the C scans, lateral, sagittal, coronal, then you decide on the entry point and you stick to those entry points. You need to evaluate the anatomy adequately before you embark on all these ventures. You must look at the whole spine, the whole cervical spine at least, and make sure that there is no other injury, because these are major traumatic events. If something can fracture odontoid, which is protected behind the strongest ligament in the body, then it's high chance that there is some other injury as well. So you must not forget to look at the rest of the spine, and you please have a salvage procedure in your mind. If this doesn't work, what am I going to do next? And once you have all these things in place, I'm sure the results are going to be as good or even better than what we have. Thank you very much for your attention.
Thank you very much, Professor Kale. I thank you especially for this eye-opening grievous consequences of the neurosurgical procedures, especially for the younger generations of the neurosurgeons. They must see the patient, examine the patient completely, as the lower spine, lower part of the spine is affected in 2 cases, as Professor Kale has shown. So this shows how intricate and how grievous can be the neurosurgical procedures without proper assessment, both at the operation table and pre-op. So this is a great eye-opener for the younger generation. Thank you very much. Any questions from the house?
Sir.
Das, please.
Congratulations. It's an excellent paper, and it's how we look ourselves in the mirror. I have only one question. The one you had vertebral artery involvement, was there bleeding?
Well, the surgeon denies it, but I wasn't there in the theater.
Yeah.
He says so there was no problem.
Yeah, but we had recently one patient, so Dr. Satpathy was operating. One side there was bleeding, so he decided to immediately give the screw. And later on, when you had an angiogram, that side was certainly involved, the other side was patent. So we didn't have any complication, but suddenly warning bleed was there.
So just to add one point, so can I? Yeah. So if suppose you are doing a C1, C2 transarticular screw fixation or trying to put a screw in C2 pedicle, and on one side or on the first side you are operating, whichever side it is, if you hit the vertebral artery, the best thing you can do is to put the screw, put some bone wax, put some Surgicel, gel foam, whatever, and put the screw. That's going to stop the bleeding. But please abandon the procedure. Don't try the same screw on the other side. That's the best thing to do. At least one side vertebral is going to be saved. That should be done. If you hit the vertebral, don't panic. It is very difficult to expose the vertebral and repair it. Now that has also been done. I haven't shown all that, but it can be repaired. But it's a tremendous procedure, and a surgeon with that experience needs to be available in the theater at that time. But the simplest thing you can do is to put the screw on that side and avoid the same surgery on the other side, in the fear that you may damage the other side as well, and then you are in trouble if you damage the other side. So best thing to do is to have a backup plan. If I hit the vertebral, what am I going to do? You must have a backup plan and then proceed. And if you do hit it, put the screw, abandon the procedure, and go to your backup plan. Do the second operation.
And it is C1, C2, whether you will, and there is an option of anterior fixation. So should you go for only anterior fixation, or you do global fixation, or you just, again, knowing that there is already a vertebral artery thrombosis on one side, you will go for some other procedure instead of putting a transpedicular screw and all?
The indications of odontoid screw are very clear. So if you can put an odontoid screw, go ahead. That's a much simpler operation than a posterior fixation of C1 and C2.
Okay.
Yeah, please.
You use the O-arm with neuro navigation or the O-arm only?
Yeah, we use the O-arm. I mean, this is in the trauma center. So in the trauma center, O-arm is the best. It works very well.
You don't prefer that neuro navigation associated with the O-arm?
The neuro navigation, we have it in our main setup, in the main building. So, but the trauma center will soon get it. But if you have the O-arm, you can actually navigate with the O-arm. So you don't need a stealth or a Medtronic navigation. The O-arm itself has that capability. They provide a smaller machine with that, and you can navigate with that. Okay, thank you. Thank you for your attention.
Thank you, Professor Kale. And now the next speaker is Dr. Prakash Singh. He will be talking on the management of missiles injury of brain.
Before going that, I would like to speak something about Dr. Major General Prakash Singh. He has graduated in the year 1976 from IGMC Shimla. Post-graduation was done in the year 1982 from Armed Force Medical College, Pune. He has done his MCH neurosurgery from PGIMER, Chandigarh in the year 1990. He has served in various neurosurgical centers of Indian Army and had got opportunity to deal with missile injuries of the brain while posted in Jammu and Kashmir in the year 1999 during Kargil War. He has been awarded VSM by President of India in the year 2007 for services rendered at R&R Delhi. He has about 40 papers in the various journals in his credit and has retired in the year 2012 and presently working at Max Saket, New Delhi. He was the Senior Consultant, Neurosurgery Department of Armed Force Medical Services. Let's have a huge round of applause for Dr. Major General Prakash Singh and welcome to him for the topic. Thank you, sir.
Good afternoon, ladies and gentlemen. My regards to chairpersons and special thanks to Brigadier Sahu, with whom I had the opportunity to work during our services. Thank you for that introduction, probably not so well deserved. Anyhow, let's get to the business of missile injuries of the brain. Do you have that? Okay. In the early part of medical history, that's what the father of the medicine said. Let him who wishes to be a surgeon go to the war. And the first person to go to the war was Ambrose Paré, and he said, in the pursuit of his profession, a surgeon cannot get a better opportunity than the war zone. However, things have changed over a period of time, and management of brain injury due to missiles, we started learning this lesson during the world wars which we had in the last century. It is still a thorny issue to resolve. And it is also known that missile injuries are most fatal injuries in human body. And if there is no fatality, they are associated with huge morbidity. The problem of dealing with missile injury of the brain is that it is in the backwater of the training. You don't get opportunity. And they are also not important from your academic point of view. And if you get opportunity, the volumes are very low. And once we are in the war zone, you have to face them and to learn how to deal with them. However, the time has changed, the world has shrunk, and wars are not fought in barren lands like Mahabharata or even the border areas. The war has been brought to our doorstep by technology, violence in society, and terrorism. You can have them anywhere. We have seen in Indian cities, the examples are shown on the slide, and very recently in Las Vegas, one single man was capable of killing 63 people and injuring 500 within 1 hour in a gathering. We are all aware this happened on just a month back. Before we deal with this, we must understand what is a ballistic physics. How does a ballistic injure the brain? We have bullets which carry kinetic energy, and that kinetic energy is the one which damages the body tissue and particularly the brain. We divide them into low velocity and high velocity. A speed which is less than 2,000 feet is low velocity, and high velocity is more than that. The shrapnel which is used by terrorists can vary their speed from low velocity and high velocity. This is a good example. We all know 16th President of US, Abraham Lincoln. He had a pistol injury, he had a low velocity. He survived 10 hours. Whereas Jeff Kennedy was shot from 200 meters away in 1963 and he died in his car instantaneously. So that is the difference between low velocity and high velocity missile. And what does it do? Once it is fired, it has energy, but by the time it hits, the energy becomes a little less. So it is the terminal velocity which is the important. It's not the weapon velocity which is important. And many people have carried out the experiment. If you fire it into an empty canister, nothing happens to the canister, the bullet passes through. But if it is filled with water, the canister blasts. And if you put it in the clay with a high velocity, there is a temporary cavity which is formed. This was the earlier experiment. Most of them were done by Sir Victor Horsley, but there was animal studies and they confirmed what happened to the brain in canine models. And when such a high energy is transmitted to the brain, instantaneously there is a tremendous rise of intracranial pressure to the extent that the brainstem function can stop, there is apnea, and even tonsillar herniation can occur, and a person can die instantaneously. Then over a period of time, there is shock waves effect, there is secondary missile and edema and so many other issues come up. But another thing which is with the missile injury, there's the integrity of the brain covering is breached and they are susceptible for infection. There are many things which happen to how the missile injury is transmitted. There, I think we'll leave this because of these blasting mechanics, there can be sometime high transmission of the kinetic energy and sometime low. Pathophysiologically, there's a tissue damage which is due to kinetic energy transmission and shock waves, and because of breach of the skull, there could be secondary missiles. And when we look at the physiology, there is a effect which we all know, that cerebral perfusion is affected by raised ICT, and which is depends on MAP and ICP. And once CPP is low, there is ischemia, and we know that brain requires constant supply of glucose and oxygen. Once ischemia, there is a further brain damage. There was a study which showed that skull wound and brain tract culture, they can give you indication that if the brain tract culture becomes positive after some time, not immediately. That means if this integrity is broken, then after some time or 4 hours or so, the infection gets in. If it is dealt earlier than that, then there is no infection. Therefore, early treatment of craniocerebral missile injury is mandatory to avoid septic complication of this injury. In addition to this, there could be other body injury which should not be ignored because of the blast effect, like lung injury, abdominal injuries, or eardrum injuries. It is very important to have a proper hospital care, because if the pre-hospital care is not good, there can be tremendous damage to the brain before any treatment can be substituted. So there should be airway protection, there's saturation maintenance, there should not be any hypotension, and they should be properly evacuated. The slide shows these are one of the blast injuries or terrorist attacks in Delhi, and this is how the patients were being evacuated, right in the center of the capital. So that shows that we do not have as yet properly trained personnel how to evacuate or handle a casualty during such crisis. Whereas in services, we have got paramedical staffs, we have got equipment, stretchers, everything. The buddies knows how to carry a casualty. So every soldier is trained to provide first aid. Then we come to the hospital, the clinical evaluation is nothing different from other neurological examination of head injury. Only thing, because scalp has hair, you may miss, so it's better to shave them off earlier and examine the scalp properly. And then we have to triage them in the casualty. That means you have to prioritize patients who need immediate care. So our emphasis is patients in priority 1 are on which require intubation, 6 to 8 Glasgow Coma scale, and those with 8 to 12, priority 2 early surgery, and priority 3 is 13 to 15, which can be handled later. We have also have a category 4, which is moribund patient, because in a war time you have to utilize your resources appropriately. So those with GCS of 3 and 5, pupil dilated fixed, probably will not pay much attention. So from pre-treatment, this is a pre-treatment algorithm. That means from the scene of injury, where would you like to resuscitate them and then transfer them whether to a zonal hospital or a neurosurgical center. Preferably, the quantity of brain damage defines missile tract, will show you, and quickly help in therapeutic decision making in planning surgery. It will show you various, these are the cases which we handle. It shows you small injuries, shows you. MRI is usually cannot be done because of metallic thing, but when in case the bullet has passed through, one can do MRI. This is a case which I had to deal with. So, was a VIP patient. People were fixed and dilated. At pressure areas become very difficult. Even clinically, you think this patient is not going to survive. And there was pressure on me that to operate this patient. Luckily, we had MRI, and once I showed them that this patient cannot be, we cannot do anything because there already brainstem injury in this patient. Sometime you may need cerebral angiography, particularly in a patient like this, where injury or hematoma is suspected near the circle of Willis. So they may have vascular injury. Of course, other investigation as you do, but what is more important is that we take a culture from the track at the time of surgery. In case the culture comes positive, you can change your antibiotic course. Evacuation is very important. Early evacuation to a neurosurgical center will give definitely better results. And this has we learned from history. Second World War, the evacuation was more than 24 hours and bacterial contamination was 80%. In Vietnam War, evacuation was by air. They reached early, the contamination was less than 20%. And we know that brain edema takes some time to develop. So if this patient come early to a center which is equipped with CT and facility to deal with this injury, or result are going to be better. And that evacuation generally is possible by air in a war zone. We still find in cities like Delhi or our metro, a patient who has got a gunshot wound may get stuck in the traffic and may not be able to reach a hospital. So probably some air evacuation plan we will need in future for these crises when they occur. Management at neuro center will depend on clinical assessment, imaging, and that is CT scan. We have a criteria, GC is 6 to 13%, mass effect, bone fragment more than 3, they will require surgery. Lacerated scalp wound less than 2 centimeter, and pulp brain oozing will require definite surgery. So AMA surgery is to remove mass, lesion, hematoma, contusion, remove necrotic brain tissue, edema, to prevent scar and seizures, to remove devitalized brain tissue, and to restore the integrity of the brain covering, to prevent CSF leak, because that is the main culprit for your septic complications. And best time to do this is within initial 3 to 4 hours, in case possible. So what surgical technique is that we prepare the whole scalp, debridement the scalp wound, and then you can extend it into S or Z shape. That maybe at times you may be to do conventional flaps. Then you can do a craniotomy or cranectomy. You must expose the dura completely, where dural injuries. Removal of brain tissue and necrotic tissues is the main prime aim. Whether to do craniotomy or cranectomy is left to your judgment. Cranectomy is more fastidious, and if in case you are not very, as a neurosurgeon, all of us are capable of doing craniotomy, but at times our general surgeons also handle these injuries. So cranectomy can be done in case one cannot do, but the results with craniotomy are better, and it should be done when the communication is less. There's a large expo required, and early surgery within 6 hours. If you're doing late, then it's better to do cranectomy. And how much debridement of the bone tract is to be done, this will come by experience only. In the Second World War, in Korean War, there was a lot of bony fragment left, and there was a lot of septic complications. So even at that time, it was advocated that do a re-exploration. If on X-ray you see a bony fragment. Whereas in Vietnam War, they did a much more radical. They removed the normal brain to the extent of 0.5 to 1 centimeter till the healthy brain tissue come. So that's too aggressive. Their infection rate came down, but the results didn't improve. So subsequently in Iraq War or Croatian War, Israel-Lebanese War, we shifted from aggressive surgery to a less aggressive surgery after the availability of CT scan, when we could judge what is the damage, and only removed the necrotic tissue. And the results of less aggressive surgery were much, much better than more aggressive surgery. during your surgery, you do a duroplasty. With most of the time, at that time, and probably in gunshot wound, it is better to use a autologous tissue pericranium, which is easily available. At times, you can fix these small bone fragments. Only thing, ensure that it's tension-free closure. At times, you can have dural sinus injury, the one shown in the slide, which you had. Despite surgery, this patient we could not salvage because it was in the middle third of the sinus. Despite repair, we lost this patient. So it's very, very difficult repair to do. And vascular injuries, I've already talked. So our philosophy in the surgical approach is that if GCS is very poor, people are dilated fixed, no surgical intervention. If there's GCS is good, surgery less than 6 hours, and no EDH or SDH, you can do a simple scalp closure, no need to go inside the brain. And in case GCS is 5 to 10 and there's a huge contusion or hematoma, then do an elaborate surgical exercise. One word about exploding bullets. They are not authorized by Geneva Convention to be used in the war, but for terrorists, there's no Geneva Convention. And these bullets are available in grey market. They have a halo at their terminal end. And while dealing with them, it could be disaster to the surgical team. So on your X-ray or CT, you should be seeing, if you have a doubt that this is a bullet which will explode on when it hits the individual or a target. At times they do not explode, and then you have to remove these bullets which have not exploded. Then you have to take special precautions. This was a case which was done in 2011 in Afghanistan conflict and safely done by the surgical team. This is the one. At times the brain is too much swollen, and of course all of us know that you may have to take a call on decompressive craniotomy, and if the brain is tense, do not don't put the bone back. At times these patients have bullets which are in ventricular system, maybe in a subarachnoid space, or they are too heavy. So by the time you take them to the OT, they can shift in case you are ill. So if they are in the ventricular system, you can remove them with the endoscope. Otherwise, intra-op imaging, to locate them, you have to do. Otherwise, don't go after them and cause more damage in the brain. In the post-op care, normal care of raised ICP, antibiotics is a special thing. You have to provide a broad spectrum coverage with the third generation cephalosporin, vancomycin. Metronidazole is only required in case the patient come very late or there is a trans-sinus injury going to the air sinus. And they have to be anti-meningitic doses because they are most likely to have infection. There are various combinations which has been given. When there was no antibiotic, then sepsis was 25%, in Seconal sulfur and penicillin came 14%, Vietnam War 3%, and now the infection rate is much, much lesser when surgical techniques have improved. These are a few post-operative scans of our series. Intracranial sepsis will only develop in case there is a CSF leak, otherwise not. This is one of the cases who had orbitocranial injury and there was a persistent CSF leak and he developed brain abscess which was subsequently tackled. Antiepileptics are must in these cases because there is a high incidence of seizures, so that you may have to continue them for a longer time and maybe lifelong in some cases. The outcomes depends on GCS mainly and extent of injury. In our series, we treated about 70 patients. One was lady, rest was the men, and age was about 28 years average. We did 44 craniotomies, 10 craniectomies. Bone were replaced in 5 simple closure and done 2 cases. We have not operated 16 patients. We had aspiration pneumonia and 3 DVT, 2 wound sepsis, 2 hydrocephalus and 2 CSF and 2. But we had no case of sepsis or meningitis. These patients were followed up for 6 months. So this is our outcome, and it is mainly on GCS. The predictors of good outcome or bad outcome are multilobar injury, hemorrhage, ventricular hemorrhage, and vascular injuries. At 6 months, we had good outcome in 70%, with that disability in 12%, severe disability in 10%. We had 6 deaths, about 8%. When we compare to the other series, they are quite comparable, rather better than earlier series when more aggressive surgery was done. This issue we have already discussed. Craniotomy and cranectomy also has been discussed. And in conclusion, gentlemen, missile injury of the brain constitutes a special group. Need of safe and effective evacuation is essential and preferably should reach within 4 hours. Maybe much earlier, but preferably. And beyond that, it becomes difficult. Surgery has to be individualized to each patient's requirement after analyzing its data. With the availability of CT scan, less aggressive surgery has given better results. Bone and missile framing alone will not increase intracranial sepsis rate. Craniotomy, where feasible, can be done. It gives better cosmetic result and avoid second surgery, but it needs finer judgment. And this was the place where I worked in J&K Udhampur, Man area. It's a beautiful place. We had a helipad in the campus where evacuation was possible. Thank you very much.
Thank you, Dr. Singh, for an excellent presentation. Any questions from the audience? Dr. Tripathi.
Regarding the repair of the dura, I've in fact used very few cases of this dura, the collagen, duragen. So if you have a very extensive damage, especially by the missiles, and you don't have local donor for the duroplasty, and then you don't want to have another incision, patient has lost blood, especially kids. We did recently one kid and was run over by the jeep, reversing jeep. So we use the Duragen and just put on it. I'm sure you know the Duragen collagen. Expensive, but really very helpful in preventing CSF leaks, meningitis. Thank you.
Yeah, at that point of time, this was not available. But general principle is don't put any foreign material because you don't know how much is the contamination. So even if it is there, electively when you're doing elective surgery, there's no contamination. But by the time these patients reach you, and by the time the culture comes, so the problem is only the contamination of injury, missile tract.
Yeah, it's a very interesting presentation. In civilian practice, there is a little difference. Yours, as you have shown, it's extremely organized, and very quickly the patients are transported to the ideal centers where best treatment can be given. Where in civilian practice, there is an obvious delay, which has already been pointed out. And I worked in Varanasi for a long time, and my colleague Dr. Chandra in Patna. So we had, both of us, a large series of missile injuries of the head, bullet injuries. And it can be called that both cities are compared to Texas of India, because most of the people talk with a pistol or gun on the head. So the types of injuries were a little different. There are shotgun injuries. Quite often you find a spray of small bullets, pellets, and some had entered into the skull or stuck in the skull. The problem is that the patients, they always ask for the bullet. Show us the bullet. Because people over there are very, very demanding, and until they see the bullet which has been taken out, they will not be satisfied. So the question is, as you have pointed out, that the bullet can migrate because of different reasons. There are patients in which there is a shotgun which is fired through the nose, and it remained in the ventricle. We didn't try to take it out. No endoscoper was available in those days. And the patient was perfectly normal for 40 years. And he, being followed up, he did the police service. And so it is sometimes not necessary to go for pellets or bullets in the brain, because it will produce further damage until you have pinpoint the localization of the metal where it is present. The other is, as you said, that the results are much better over here because of the rendering service as quickly as possible, because the major problem following the bullet injury is not the bullet which is producing the damage, the hemorrhage. It comes up so fast, and if artery is damaged, the hematoma will rapidly be produced and the herniation will take place as quickly as possible. So as you are telling that the important thing is to deliver the treatment as quickly as possible, not running after the foreign body which is lying there. That can be taken out even much later. But the hemorrhage has to be controlled as quickly as possible, and the other things, that is lacerations and even bone fragments, which are produced, the bone fragments, and get into the brain and produce small foreign bodies, they have to be taken out. So this is a very important part. I think your result is excellent, and I think it can be applied in the civilian practice also in future.
Yes, very true. This shows that there is a bullet in the ventricle, and we have not touched it. It remained in this. It didn't cause any problem. But at times they can cause hydrocephalus if they migrate, and in that case endoscopically. And we have not gone after the fragment because our post-op scan shows that many fragments are left, and if you chase them, it will cause more damage than, and they don't cause any problem. Thank you, sir. We had gone. I had gone through your paper from BHU of civilian gunshot wounds.
Any other person?
One child is suffered from pellet injury accidentally. Now he was operated and he was cured. Now he is adolescent, and once and twice in a year he is having tonic-conic seizure, and it is this pellet is around the frontal lesions. It is approachable. So do you think that to control the seizure, we have to take out the pellet is a better idea, or not to touch it?
That will, I think, will depend. It is known that bullets which are copper coated, they are more epileptic. So, and in case you can localize the on EEG or video EEG, that this is the focus of the seizure, I think, and it is in an approachable area, it's better to remove it along with the scar tissue and may get relief.
Any other question or comment? If no, then thank you very much, Major General Dr. Prakash Singh. I think with this we come to the end of the session.
We have come to an end now. I would request Dr. Prakash Singh to felicitate our chairpersons on dais, please. Sir, I would request you to felicitate Professor Dr. Chaudhary N.R. Nanda. Thank you, sir. May I request you to felicitate Dr. Maya Gantayat. Thank you, sir. Now Professor Dr. R.N. Sahu. Now I will request our chairpersons to felicitate Dr. Prakash Singh all together. Thank you so much. Thanks to the chairpersons. Thank you to the speaker. Now we have come to the valedictory function. Before that, I would request all of you to come forward for a group photograph. So kindly come forward. I would request our DNB students also to come forward for the group photograph. I would request everyone to wait for the valedictory function. Close any. नहीं बंद करना से खाली वायर उड़ा कर रख दे स्लाइड किन देखिए आसे स्लाइड देखिए रची के I would request everyone to stay for the valedictory function 5-10 minutes more. I would request Dr. B.K. Kuar on the dais, please. Oh, sir. And Dr. P.K. Sahu, sir.
Kindly sit down, so we can finish quickly. The first is a good declaration, I think, it's a good suggestion also. We have decided that all the delegates coming from outside India to be our honorary members of Neurological Society of Odisha. As you know, we have a Neuro Club. From Odisha, we have a Neuro Club where all neurologists and neurosurgeons are all members. So we want that all of our speakers coming from outside India, we want to accept them as our honorary members to be registered in our society. Okay? The next is announcement of the result. What is the result? Result is the award paper. So who is the winner? Let us guess someone. So the first prize goes to this one. Chandan Khede.
Abhijit Chandan Khede.
Yeah. Abhijit Chandan Khede. Have a big clap for him. The second prize goes to, there are 4 I think contestants. Dr. Balwant Singh. Somebody can accept the prize on behalf of him. Okay, we congratulate both of you that you have won this competition. Third one, this is the कौन करेगा पड़ेगा? Now at the end, we request the delegates coming from outside, Professor Peter Rale, to give his own comments. What was about the academic session?
Thank you. Well, it's been a very interesting and full 2 days of meetings, and it's wonderful for me to see this coming together because Dr. Sahu and I have exchanged emails regularly over the last 6 months and have, as the program has been unfolding under Dr. Sahu's direction, and so I particularly like to thank him and to thank the chairman of the organising committee, Dr. Kanu, and his colleagues, and all the participants, all the speakers, and also the participants, because it's been the exchange of ideas, the questions and answers, the discussions that have really make the meeting valuable. And I think for me, and I'm sure for my colleagues from the AASNS, this has been an exchange of information from us to you and from you to us as well. And it's that exchange which I hope can help us all to have a better way of dealing with the problem of neurotrauma in our different countries. I'd like to thank also, in addition, my own colleagues from the AASNS for making the trip and for their very active and very valuable participation. So thank you, everyone.
Thank you, sir. I invite Professor Sanatan Roth to speak few words, at least his own comments, own observations.
Friends, I have been attending conferences since 1965. I think this is one of the very good conferences I attended. It was very well attended, organization was excellent, and everything. I have nothing to complain about the conference, and I interacted with the people who have come from outside. They also liked the conference very much, and at the end I appreciate the organizers' efforts to organize in this way, which has been really helpful for the scientific community. Thank you very much.
Thank you, sir. Professor B.S. Das. Few words, sir. Your sweet words give us encourage to have the second session.
As usual, the validatory function, the residuals are there. Throughout, it has been a good, organized, well organized, on time starting and on time finishing sessions. Only thing is that I would have thought the below 50s should have been more active. The below 50s have to be more active. Then only we would know that is the progress. I think till that time we are proceeding towards progress. Thank you very much. It's well attended, well done.
Thank you, sir. Now I request Professor R.N. Sahu to come to the desk.
Thank you very much for this invitations and all that. I remember when I was a small child in the village, the elders used to come, Ayushman Bhava. So I'm doing that same job here because I have become too old. Now I'm giving Ayushman Bhava to both organizers and the organizations. So long live this, long live the organizers, and long live this organization. So thank you very much, and please continue this in future and make it stronger. Thank you very much.
Thank you, sir. Now I request any one of us sitting here can volunteer themselves to come and give some opinion.
Speak from here. Well, Brigadier Dr. Sahu and Professor Kumar and leftover delegates. This is a very useful sort of workshop type of thing in which we could have the presentations by our younger colleague from Korea and Japan. This is what he said, that Professor Das said that we should have some of the younger colleagues or trainees, because their presentation is superb as far as the research part is concerned. In India, we see lots of cases and the clinical experience is fantastic. But as far as the research part is concerned, it is little behind the other advanced countries. So I wish that that part was missing, the younger person's participation over here. And they missed it. As far as I am concerned, Professor Sao and Professor Kumar have tried their best to invite them and requesting them to participate, but I don't know what is the reason. Professor Das also was pointing out that below 50, no, it may be below 30 or 40 would have been much interesting for them to participate in this. Otherwise, this was highly organized function, and we are all benefited, even if we have finished the major part of our productive career, but still we have learned a lot of things from the presentations by our invitees and as well as our own people. I must tell you that the organization was headed by Dr. Brigadier Saho, and he had brought army discipline into this as regard punctuality and other facilities and so on. This reminds me, as Professor Saho was telling, our childhood, but when I joined All India Institute of Medical Sciences in Delhi, I was little, as usual, passing from Cuttack Medical College, little relaxed, little easy. Then one day, Professor Tandon got hold of me, said that we are not in the army hospital, but I tell you, I want army discipline. So that changed my career. So this is very important, that rarely we find such amount of discipline, punctuality, organization, flawless sort of a meeting. Thank you, both of you, for doing this, and I'm sure we'll enjoy if it comes up in future.
Thank you. Thank you, sir. Dr. Tripathi, you want to say something?
A small complaint and a small guhari in Odia, that people from outside Odisha, I mean, I am Odia, of course, but non-Odia people, they cannot just come to Odisha and go back without sightseeing. So may I request for all your future programs to keep at least half a day sightseeing. In fact, you can have the conference on the bus itself. Put a TV and 2 buses, and you really enjoy, and bonding is more. So with that suggestion, I really thank you very much, and I'm sure you take my suggestion as a request. Thank you, sir.
If you see the program, 6th has been kept as for the sightseeing, but most of them have left because of some busy schedule, because they are said engaged, and they have preponed their actually visits and they have gone before. But this is kept in mind, and for 6th also some of the guests they are staying, and we are making arrangement for them. And is there any other volunteer who would like to speak few words? Professor Ghosh would like to few words.
At the outset, I should thank Professor Sahu and Professor Kanwar for inviting me to join. This is second time I have come. I should appreciate the hospitality and the arrangement of this conference, and I still believe I will come again whenever they will call me and enjoy the deliberations, and still we want to learn like the juniors. So again we thank you.
So I close the seminar, the trauma session, but at the end, as you know, today is Chhadakhai in Odisha. Everybody is interested to take, after a month of So you have to have good food, fish, meat and chicken. So that is, everything is ready outside. I think everybody should go and enjoy.
You are all invited.